Welcome to Kolkata. Hope we have a great academic feast over here. I will be speaking on the anatomy pertinent to the lumps and bumps of the eyelid. I have no financial disclosures. Now coming to the anatomy, the lid consists of the anterior, middle and the posterior lamella, the skin, the orbicularis, the tarsal plate and the conjunctiva. And again has the epidermis and the deep dermis. The deep dermis harbors the neurovascular tissue, the hair follicle, the apocrine and the eccrine glands as well as the sebaceous glands. Now coming to the primary lesions of the skin. Firstly, we know a macule is a flat lesion measuring less than 0.5 centimeter. Anything more than 0.5 centimeter or 1 centimeter will be a patch, but it won't be raised. Now coming to a papule, it is a solid elevation less than 0.5 centimeter. Anything more than 0.5 centimeter is a plaque, but it does not have much of depth. Now coming to the nodule, it is a solid elevation with a greater depth. Now coming to the tumor, tumor is a large nodule or a swelling which may be benign in nature or malignant. Now what are lumps and bumps? These terms has been used interchangeably in various literature, but what I understood from that is that a lump is a swelling within the tissue, and when it is causing an elevation in the skin, it is a bump. So whenever we see a lump or a bump on the eyelid, we must inquire about the duration and the progression of the disease. Now coming to inspection, the site of the lesion must be noted carefully, preferably with a diagram, the size of the lesion in all the 3 dimensions, the shape of the lesion, the surface whether it's irregular or smooth, the surface pigmentation, the loss of lashes, any surface ulceration, the overlying skin, and the loss of lid architecture, as well as the regional lymph nodes. Now coming to palpation, the consistency of the mass, whether it's soft, firm or hard, the localized tenderness or temperature must be taken note of. Translumination must be done in case of cystic lesions. The mobility and the fixity of the lesion either to the deeper tissues or to the superficial tissues must be taken note of. Finger insinuation must be done where in case of lacrimal masses or orbital masses. Now reducibility must be done in case of lid masses. Now coming to the appendageal lesions, this lesion that we see here, it is basically a comedone. It is caused by blockage of the dilated hair follicles with keratin plugs. This small lesion is a syringoma. It is a tumor of the eccrine gland. This lesion is a xanthelasma. We see a papule over here. It is caused by histiocytes which are laden with lipid, and it lies in the dermis. Now the 4th lesion basically here, it is the milia. It occurs in crops and presents as multiple papules. Now these are eyelid bumps which are smooth in structure, rounded or ovoid. They are fixed to the tarsal plate, and on eversion we can see the yellowish tinge. So these are basically chalasia. Now coming to the lid margin lesion, this is the marginal chalasia. As we evert the lid, we can see the yellowish tinge. This is the cyst of mole occurring at the anterior lid margin. This was a unique case. These excrescences that we see are basically dystrophic calcification. This patient was a case of tumoral calcinosis. Now coming to the pigmented lesions. When we see a pigmented lesion, the variability of the pigmentation must be noted. Any abnormal vasculature and localized erythema must be taken note of. These lesions, which are basically seborrheic keratosis, they may have a look of the stuck-on appearance or may have this verrucous type look. Now coming to cystic swellings, the first swelling that we see here is of a epidermal inclusion cyst. It is rounded ovoid. The second lesion is of a cyst of mole. The third lesion, extremely on the right, extreme right, is basically a eccrine hydrocystoma. It presented at a medial canthal swelling or a medial canthal lid mass. And the 4th lesion is basically a sebaceous cyst. Whenever we see a cystic swelling, we must go for transillumination test. Now coming to the diffuse lid masses, these lid masses have a bag of worm feel, and they form the S-shaped upper eyelid deformity. So these are basically neurofibromatosis. Now coming to the soft tissue swellings, a soft tissue swelling in the lower eyelid or the upper eyelid may be due to an underlying conjunctival cyst causing a lid bump, or it may be due to steatoperiferon in the lower eyelid or the upper eyelid. For the lower eyelid, whether it's fat or fluid, we can rule it out by asking the patient to look up. Fat disappears but the fluid remains. Now coming to the periocular lumps, these children have history since birth of these swelling which are fixed to the deeper periosteal tissue. So these are dermoid cysts. Now this was a cyst in a young boy with history of 1 year, which was soft in nature and not fixed to the superficial or the deeper tissue. So this was basically a lipoma. This was a unique case. This boy had recurrent swelling in the lateral orbital region. It was hard on palpation, and on histopathology we found it to be a chondromyxoid tumor. Now coming to the vascular lesions, they can cause lid bumps as well as facial bumps. They may be an arteriovenous malformation which will have the bruit and pulsation, or they may be in the form of varices which will be positive on Valsalva maneuver. Now coming to the ominous lesions, the ominous lesions have the variegated appearance, variability of pigmentation, there is loss of lid architecture or the lid margin. It may be presenting as a cutaneous horn. They may have a surface ulceration and a surrounding everting edge. Or in case of SGC or sebaceous gland carcinoma, they may present as recurrent blepharitis. Thank you.
Thank you, Dr. Sripurna. That was really a very excellent talk, a very lucid talk, I should say.